type 1E is when extrahepatic, so stone both in the intra and extrahepatic bile duct. So the patient which we have discussed the clinical scenario in the first part, we are dealing with the type 1E because he had stones both in the intra and extrahepatic duct. So if they are duct on the right side only, then we can add R or L according to the side of both and LR. So in our case, if you remember that patient, he had stone bilaterally. So our classification for that patient will be 1E, that is type 1E, more intra and extrahepatic with L and R, and choroid lobe was not involved. So 1E LR will be the classification for our patient, the subject in hand we are discussing. Welcome back, viewers. So this is going to be second video on hepatolithiasis management, and the first video we have already uploaded. So the main highlight in this video will be the creation of access loop, different type of access loop, the relevant literature review, and the classification of the hepatolithiasis according to the extent of the stone burden or according to the symptoms, like Tong classification or Tsunoda classification, and what are the advantage and disadvantage of the different type of the access loop. So this is going to be only theoretical discussion, and in the next video we will be showing the hepatolithiasis surgery, that will be excision of the extrahepatic bile duct and creation of the hepaticojejunostomy with access loop, that will be with the stomach in our case, and we will discuss theoretically what are the different types of the access loop for the benefits of the students. Friends, I hope that you have already watched our previous video. That is the first part of this series, the etiology, the clinical case scenario. We have already discussed in length, so that it is highly desirable that you watch that video first. Briefly, this was a case of 62-year-old gentleman who has presented with acute cholangitis. The grades of cholangitis we have already discussed, and the same video is also free as a bonus content on our app and also on the YouTube. So please do check that. We managed that patient conservatively with the help of antibiotics, IV fluid, and then we did emergency ERCP stenting. These are the images which were showing of the extensive stone burden in the extrahepatic and intrahepatic bile duct. So the concept of primary and the secondary hepatolithiasis, that is when the hepatolithiasis is because of some external obstruction in the extrahepatic bile duct, we have already covered. And then this was a type 3B biliary that is also covered, so I will not go again into that kind of discussion. Friend, hepatolithiasis is a very complex and challenging subject or concept to understand. It's equally challenging patients these are to manage. So we are trying to simplify the subject, the concept for the benefit of students and friends, my junior trainees and budding surgeons who are preparing for the super specialty examinations or other examinations. They will find this content very helpful because many of the MCQs are based on these questions, and we have covered theory in detail. We have given the relevant literature backup, so you will get benefited. So stay tuned till the end of this video. First of all, let's see what are the different classifications by hepatolithiasis. Friend, this classification is one of the simplest classification you will find, and it's given in the Bloom-Gart. So this is by the Japan Research Group. It is type 1 and type 1E. So type 1 is when they are stone only in the intrahepatic bile duct, and type 1E is when extrahepatic, so stone both in the intra and extrahepatic bile duct. So the patient which we have discussed the clinical scenario in the first part, we are dealing with the type 1E because he had stones both in the intra and extrahepatic duct. So if they are duct on the right side only, then we can add R or L according to the side of both and LR. So in our case, if you remember that patient, he had stone bilaterally. So our classification for that patient will be 1E, that is type 1E, more intra and extrahepatic with L and R, and choroid lobe was not involved. So 1E LR will be the classification for our patient, the subject in hand we are discussing. This is again a good classification, again given in our Bloom-Gart book by Takada and colleagues et al. In 1978. So it is according to the stricture. Type 1, there is no apparent stricture and the system is not much dilated, but they are stone both in the extrahepatic duct. In type 2, there is a stricture or narrowing at the lower end of the CVD, leading to the massive dilatation of the both extrahepatic and intrahepatic bile ducts and stone formation. So our patient, which we have discussed, had type 2 type of this classification. Type 3 is when the extrahepatic bile is normal as highlighted by the arrow, and there is a obstruction at the level of hilum, they are bile stone. Type 4 will be friends, when there is an isolated stricture in some duct, like in this pic, this type 4 will be a stricture in the left duct with the formation of the stones in the left duct only. And type 5 will be more like a multiple strictures, more like a Caroli type picture. So there are multiple stricture, multiple segments. So accordingly, I mean, the management will change, and that you will understand better. Friends, just remember these facts and figures. You can go through these papers also to have more understanding, and just remember these will be the basis of many of your MCQ questions, so you have to remember these classifications. According to a severity, there is another classification by the research group from Japan only. So it is grade 1 to grade 4. So grade 1 is patient asymptomatic, that will be incidental finding of the stones on imaging. Grade 2 patient will have occasional abdominal pain. Grade 3 patient will give history of transient jaundice or cholangitis, which will settle. And grade 4 will have a continuous jaundice, sepsis, or there is a complication like cholangiocarcinoma. So our patient had fever, jaundice, which was persisting even after the ERCP stenting, and he required 3 stent exchange before we could take up that patient for surgery. So patient had grade 4 severity of hepatolithiasis according to this research group from Japan. Another important classification by Tsunoda et al. And friends, these multiple classification means we don't have any one simple system to explain things. So there are multiple things. When we'll have one classification system which can explain all the etiology and pathology, then we'll have one. So for the timing, just remember the Tsunoda classification type 1 to type 4. Again, type 1, type 4. Type 1 is there's no dilatation like in the our previous classification. Type 2, there is a diffuse dilatation of intrahepatic duct without stricture, there is no apparent stricture with cystic dilatation. Type 3, there is a unilateral solitary or multiple cystic dilatation of intrahepatic ducts and strictures, so the involvement is unilateral. And type 4 is bilateral stricture formation with solitary or multiple friends. So accordingly, the management will change, like if there is no stricture, then simply we can drain the segment. If there is stricture, then we may have to add some drainage procedure with resection. So accordingly, the things will become clear, and we will also demonstrate in the live surgery. Classification, friends, again, it is asked in many questions, and it is one of the comprehensive classification, I will say. So up to the E level, just remember this type 1, type 2. Type 1 is localized stone disease, which is unilobar or bilobar. So if it is localized, then a patient can be offered a resection, because resection has the least recurrence rate. And type 2 is diffuse stone disease. Type 2A will be there is no atrophy of the hepatic parenchyma or stricture of the intrahepatic bile ducts. So it is simply a stone burden, but there is no atrophy or stricture formation. Type 2B will be segmental atrophy and stricture of the intrahepatic bile ducts. So there is only segmental involvement. And type 2C will be biliary cirrhosis and portal hypertension. So accordingly, you have to manage the patient. And if there are extrahepatic stones, so it will be EA when sphincter of aorta is normal, and EB relaxation of sphincter of aorta. Friends, these are a bit confusing classifications, but I can't help you out about these, and you have to just remember them. See this video time and again, just memorize them by heart, so you will remember the word by word content. The role of medical therapy in hepatolithiasis, friends. So friends, I must admit one thing, while I'm preparing these courses and video tutorials for you guys, I am also gaining new insight, because when I was going through the literature, and this was a new addition to my knowledge also, that there is role of the statin group. So as we see, so medical therapy is only supplementary role. The PCA that is usually give in our setup is a hydrofolic bile acid, offers liver cytoprotection and leads to accelerated activity of bile acid and bilirubin. Related activity of the bilirubin bile acid metabolizing enzymes and transporter proteins that increase the flow rate and decline of the bile mucin viscosity. Hence, there are some literature in which, after prolonged use of these UDCA tablets up to 12 months, for 12 and 24 months, 36 months, there has been some case series which have reported the dissolution of stones, but there are no randomized control trial. And in my experience, we usually give this tablet, but the benefit is still questionable. This was a new addition to my knowledge also, that there is a role of simvastatin. It reduces plasma and biliary cholesterol levels. That explain the thing that primarily by reducing cholesterol synthesis. So these are given as a cardioprotective drugs. And there is a reduction in CVD by lithogenicity and hydrophobicity. So by simvastatin, that might be useful. Early stage of cholesterol gallstone development, and in whom a choleretic effect is required. Personally, friends, I don't have any personal experience of using, but this rationale and the basis of giving is make it a reasonable choice. So do give me a feedback if you have any one of you have used. So for the conclusion, friends, just remember that we have option of pharmacological therapy in the form of UDCA and simvastatin. Then we have option of resectional procedures versus drainage procedure, T-tube drainage, and endoscopic versus interventional radiology, that is VTCL. And so, these are different things. Then in this series, we also discussed about the different classification system according to the stone burden and the symptoms, down classification, Tsunoda classification, and different type of access loop we have discussed. So in the coming part, that will be third part of this series, we will demonstrate the live surgery with creation of access loop and hepaticojejunostomy combined with the extrahepatic bile duct resection. So stay tuned, friends. And if you're watching this video on YouTube, don't forget to like this content and subscribe to our channel. Stay tuned. Happy learning. Thank you very much.